Thank you very much, and thank the organization for the invitation. And it is also an immense pleasure to be here in Paris, the place where I lived and worked for 1 year and a half, to talk about PSVD-associated conditions, their prognostic impact, and how treating them eventually may change the disease trajectory. We have now, it has been published last year, at the end of last year, the paper by Marta Magaz. I would call this the European cohort, and I believe that it is going to be quite quoted today and tomorrow. It gathered almost 600 patients in 27 centers for a period of follow-up of around 30 years. And what we found was that 2/3 of the patients had an associated condition that predisposes to PSVD or the entity. And importantly, there was also an impact on finding the associated condition on prognosis, as almost 1/3 of them had a severe form of the associated condition that impacted the prognosis, lowering the transplant-free survival. This important issue was also noticed in another paper that was published already this year, a Chinese cohort of patients with 128 patients, and they found that when we find an associated condition, that is also linked to a phenotype, a different phenotype of more portal hypertension in patients with PSVD. So it is important for us to always check for an associated condition in PSVD, as it may impact prognosis, not only concerning the more portal hypertensive phenotype, but also to a decreased transplant-free survival when this associated condition is severe. So we are going to take a little bit deeper in this issue. And what I present here is a table considering several diseases or associated conditions that are gathered in disease groups and the strength of association of each condition and PSVD. We have immunodeficiencies, immune-mediated diseases, the exposure to drugs or toxins, infections, hematological disorders, genetic disorders, and also prothrombotic disorders. Concerning immunodeficiencies, we have several. I am going to talk a little bit more concerning the common variable immunodeficiency, that is the most common in the adult population. And it's quite easy to achieve this diagnosis, as it is cheap to ask for immunoglobulins and to ask for the patients about recurrent past history infections. This review clearly shows that in several groups of CVID patients, we have a quite heterogeneous prevalence of different and distinct liver diseases. But when we check for NRH, we may see that also the prevalence of NRH in patients with common variable immunodeficiency is quite variable. It may be such as low as less than 1% to 1/3 of the patients with common variable immunodeficiency. But if we check the other way around, for example, in the European cohort by Marta Magaz, you may see that almost 7% of the patients had an immune common deficiency. And in the Chinese cohort, it is a little bit lower, so there is also heterogeneity concerning the place where we are in the world. Importantly, the VALDIG has an ongoing study concerning this subject about the characterization of PSVD in patients with common variable immunodeficiency. So please go ahead. If you have some patients, please focus on this. Concerning immune-mediated liver disorders, I have put it also in this box, the antiphospholipid syndrome that classically is put it in the prothrombotic condition. This is truly an immune-mediated disease, and we can discuss this later on. But this is quite important because when considering it and including antiphospholipid syndrome, we may have about 1/3 of the patients with PSVD with these immune-mediated disorders that will bring us to PSVD. And I believe that Marcos Enzo is going to talk this a little bit later. it may lead to an eventual central pathway in order to try to establish the real cause or the common pathway for this entity. As we know that more than 90% of patients with PSVD have at least one circulating autoantibody, until 1/3 of them have anti-endothelial cell antibodies in circulation. Also, there is another body ongoing study concerning PSVD associated with systemic sclerosis, case control study, so please go on and give us also some patients. Concerning the exposure to drugs and toxins, this is historical, and we know quite a lot about the association of didanosine, for example, for patients treated for HIV patients. This has a direct link with mitochondrial toxicity in beneath the endothelial cells. And we have also the exposure to thiopurines, for example, 6-thioguanine or azathioprine, for example, and these may be dose-related. And we have the exposure with oxaliplatin, for example. We know now that the probability for a patient that is exposed to oxaliplatin develop PSVD may be linked to a genetic susceptibility factor that may be together. Concerning infections, here I believe that we have a change. In the last year, 2 studies have been published considering the prevalence of chronic hepatitis B in patients with PSVD. Either in the Spanish cohort or the Chinese cohort, this was found. This is important because we have, all of us, we have patients with chronic hepatitis B in which we do not perform no longer any liver biopsies because they are not needed, and so we may underdiagnose PSVD in this subset of patients. Also, recurrent abdominal infections may be a cause, and HIV infection. Concerning HIV infection, this has been also historically connected to non-cirrhotic portal hypertension, but when we check all the papers that have been published so far, patients with HIV and PSVD, or non-cirrhotic portal hypertension, they were all under iodazine treatment. But yet, in this European cohort, 49 patients with HIV were included, and not all were under antiviral treatment. 14 patients with HIV did not have any other related non-cause. This means that HIV probably may lead itself to PSVD. Hematological disorders have been classically linked to non-cirrhotic portal hypertension, but the prevalence is going lower, and we know that there is an association clearly with myeloproliferative neoplasms. We are not going to check for all patients, besides those who have some specific complaints, but when we have a portal vein thrombosis together with PSVD, we should always think about this. For example, this Chinese study involving almost 170 patients clearly showed that the ones that had hematological associated conditions had also a more increased prevalence of PVT. This is another new box, the genetic disorders, concerning the adult population, and realizing the European cohort, it is not as much, around 5% of patients that had some genetic disorder or some familial aggregation without us understanding what was the associated condition. But when we check the pediatrician cohorts, we may see that 1/4 of the patient have any genetic disorder, underlying genetic disorder. So this is quite important, and I believe that either Silvia and Marco are going to talk and going a little bit deeper concerning this. But now we know that the biology of the telomeres, for example, are quite important and may overlap other diseases like aplastic anemia, for example. Considering the prothrombotic disorders, and when we exclude the antiphospholipid syndrome, the prevalence is lower. And so we don't check for this unless we have concurrent portal vein thrombosis. Okay, so we have checked for many associated conditions that may be linked to PSVD or to this entity. It is important to see the mechanistic insight that evokes PSVD. But what is the clear impact of treating this associated condition on the evolution, on the prognosis of PSVD? What I'm going to show you now are data based only on case reports or case series. So we do not have many more data. Concerning, for example, the association between HIV and didanosine. This case series clearly showed that in 8 patients that were treated with didanosine and were HIV, there was a diagnosis of non-cirrhotic portal hypertension, and 1 patient died 1 month later, diagnosis, but unrelated to PSVD, and 2 patients maintained treatment with didanosine. Those 2 patients rebled from variceal bleeding, and the other 5 patients had a follow-up of 16 years without any major sign of portal hypertension. So this means that changing or releasing the drug may change the future and the phenotype of disease. Concerning the use of thiopurines, this is a retrospective multicentric Dutch study that involved 43 patients with inflammatory bowel disease that were under thiopurines treatment. And you may see here that all of the 43 patients had NRH, and at diagnosis of NRH, they had disturbed liver profile, they had lower platelet count, they had an increased spleen size, and in all the 43 patients, the drugs were discontinued, and there were a trend to normalization of liver profile, an increase in platelet count, and even a decrease in spleen size. So stopping the medication changed the trajectory to a less portal hypertensive phenotype of PSVD. This paper that was published almost 20 years ago clearly shows that in 24 patients with inflammatory bowel disease treated with 6-tiaguanine, all of them performed liver biopsy. In 6 patients, NRH was diagnosed. In all the 6 patients, liver hemodynamics was performed, and in 3 patients, 3 had an increase in HVPG. All patients, we stopped the treatment, and 1 year after, HVPG normalized. So once again, we changed the phenotype. There are some other drugs that may be involved, for example, trastuzumab emtansine, that when we stop them, we have a clear normalization of the liver profile, and also we have mechanistic insight to check for the change on the phenotype. And now we stop here the drugs or the toxins, and we go and check for what happens if we treat an underlying disease. For example, paroxysmal nocturnal hemoglobinuria. What I present here is a case of a patient that had an important refractory ascites performing paracentesis, and she had a PNH. Eculizumab was started, and the need for paracentesis was stopped. The diuretic therapy a long time was decreased, and there was a resolution of ascites together with the resolution of jaundice. So, in this particular case with PNH, the treatment of the disease led also to a clear amelioration of the portal hypertensive phenotype. And finally, concerning cystic fibrosis, for example, in this patient with lung and liver involvement from cystic fibrosis, what we had was a clear portal hypertensive phenotype. You may see an increase in the size of the variceal of the esophageal varices from 2015 to 2018. In the year 2019, he started on TFTR modulator therapy, and you clearly may view that we have a decrease till normalization of this portal hypertensive phenotype. So, take-home messages. When we have a patient with PSVD, we must recognize the associated condition. They are present in up to 2/3 of the patients, and they clearly may impact prognosis, as when we recognize them, we may have a more portal hypertensive phenotype, or even if we have a severe one, it impacts prognosis, and this is a variable that we have now in our nomogram of the risk prognosis in PSVD. Also, even though we have level evidence concerning treatment and the change in the phenotype of PSVD, we have now some data, and this may be important also to check for the mechanistic insight that goes a little bit deeper concerning autoimmunity, genetic, etc. Thank you very much.
Thank you very much for this presentation. I would like to place the question, is there really drug-induced PSVD, especially for azathioprine, which I've used in hundreds of patients with autoimmune hepatitis? I don't see it. But yes, I see it, or I used to see it frequently in inflammatory bowel disease, like the case you presented. But it's a bad drug for inflammatory bowel disease, so if you change the treatment, the patients fare better. So I doubt whether it's really the drug. The same, I think, is true for the HIV treatment. And patients, of course, now receive better treatment, and we don't really see PSVD in HIV anymore. I don't know whether it's a change of the drug. I believe it's a much more effective therapy of the immune diseases, and it's probably an immune-mediated PSVD.
Thank you for your question. As a matter of fact, concerning thiopurine use, it seems not only that it may be dose-dependent, as it happens in 6-TIAGO9, and concerning azathioprine, probably it may be linked to a lower activity of thiopurine methyltransferase. We do not check TMTP frequently, but what is theorized is that the direct toxicity may be not because as a thiopurine, but from its metabolites.
Thank you. Nice presentation. I'd like to go beyond the drugs, but to supplements and herbs. I know we don't have much data, but there are supplements and herbs that can cause vascular liver disease. It's well known, like, for example, Confrey and others. But there are many others, ginkgo biloba, dipertenoids, indolic dipertenoids, germander, many others that were described. So I think we must talk about and say, don't be exposed to these drugs, at least this, while we don't know exactly the relationship, the cause effect of this supplement exposure. And it's quite common in Brazil. When we ask about the use in Brazil, when we have a diagnosis of PSVD in a patient, especially without portal hypertension, 50% of the patients reported use of supplements and herbs that can cause endothelial aggression. So,
you are completely right. There are several case reports concerning herbal products that may lead to PSVD. When we have a suspicion, I believe that we must propose it for publication also, because it will increase our knowledge. It was not possible to list here all the herbs, all the toxins, for example. And we have also the excipients.
Thank you. Ten Franco from Belgium. You mentioned just hepatitis B as a concomitant chronic liver disease rather than an associated condition. But I think it's very important that we should look into this in all kinds of chronic diseases in a very systematic way. We recently did it in MASLD, where you see a very high prevalence of some of the PSVD-like lesions. Not to say that PSVD is an associated condition of MASLD, but you see a lot of these lesions there, and probably also in other liver diseases. So I think we usually underreport and underestimate the prevalence of those lesions, and whether they are pathophysiologically relevant in all those diseases or not is still a matter of debate, I think. And as mentioned, sometimes in normal liver biopsies you can also see some lesions, but at very low frequency. So I think we still have a lot of work to do there, and not, it's just incidental reporting, and we should systematically look at it.
Thank you very much. You are completely right.